Welcome, and thank you for watching this video. My name is Cheyenne Haynes. I'm the Operational Programs Manager of the Swedish Orthopedic Institute. The goal of this seminar is to help you to feel prepared for your surgery and promote a smooth recovery. If you have questions at the end, you'll see my contact information, as well as the contact information of our Joint Program Coordinator, Kim Rains, and please feel free to contact either one of us with any questions you may have. Today we will talk about your day of surgery, pain management, preventing blood clots, the therapy you will receive while you are here, and finally, some discharge and home care planning. I start first with some safety tips for your hospital stay that will be important. The first is meticulous hand hygiene. You will notice that every healthcare professional entering or leaving your room will either wash their hands with soap and water or use a hand sanitizer gel. We encourage any visitors who come to see you to do the same thing. You will notice that every patient room has a wall-mounted hand sanitizer dispenser at the door, and visitors are more than welcome to use that. Leave all of your valuables at home. Remove your jewelry and leave that at home. You will be asked to remove all metal jewelry as well as piercings before going into the operating room. It is okay to bring your cell phone to the hospital with you. We do not have any equipment that it will interact adversely with. You are also provided with a regular landline telephone next to your bed while you are here. And finally, if you are a patient with sleep apnea, it is important to bring your CPAP machine with you to the hospital. Now we are going to start with the day you are scheduled for surgery. On that day, you're going to come to this building, which is the Swedish Orthopedic Institute, and proceed directly to the second floor. There is only one bank of elevators in this building, so whether you are parked in the parking garage below the building, or if someone dropped you off in front of the building, you simply get on the elevator and go to floor 2. The parking garage entrance and the entrance to the building are both on Cherry Street, although our street address is 601 Broadway. Once you come out of the elevator on the second floor, you will be greeted at the check-in desk and then taken to the preoperative station. At this time, a nurse will get you prepped for surgery by checking your vital signs and performing any other routine tests that may be required. This is the time that you will get changed into your hospital gown. While you are in this holding area, there are two important conversations that will happen. One, you will meet your anesthesiologist. They will come into the room, introduce themselves, and have the conversation with you about what type of anesthesia will be used for this procedure. The second conversation will be with your surgeon or their assistant. They will come into this room, and the two of you together are going to mark the area for surgery. This is a pen and initials on whichever hip or whichever knee you are having surgery on. This is a hospital policy, and it is a very important step in our safety process. Of note, you are welcome to have your support person with you at this time. From the preoperative station, you are now taken to the operating room. This is, of course, where your surgery will be performed. You are still on the second floor of this building. On floor 2, we have 10 operating rooms, all used primarily for orthopedic surgery. From the operating room, you are now taken to the recovery room. Again, you're still on floor 2 of this building. You might hear the recovery room referred to as the PACU. That stands for Post-Anesthesia Care Unit. And it is exactly that. It is a unit where you will spend 1, possibly 2 hours while whatever type of anesthesia you had starts to wear off. This is a very closely monitored period of time, and family members and friends are not allowed into this area to reunite with you yet. For those family members or friends who might be waiting for you, the surgery itself will last 1 to 2 hours, and the time spent in the recovery room is also about 1 to 2 hours. So someone waiting for you will wait a 2 to 4 hour stretch until they get to reunite with you after your operating room and recovery room stay. There is a very large waiting area on floor 2. It was in front of you when you came off of the elevators at the check-in desk. In that waiting area, there is an electronic board that tracks the patient. When the patient checks in for surgery, they are assigned a number combination or a case number. That number combination is put on a piece of paper and given to the family member or friend who is waiting. The board then tracks the patient through their progress, and it is color-coded. So you will be able to see when the patient has gone into the operating room, when surgery begins, and when they move into the recovery room. The surgeon will also contact your family member or friend following surgery to discuss how surgery went. Now we are shifting gears back to the patient. Once you are awake and alert in the recovery room, and it is deemed safe to send you to the orthopedic nursing unit, you will be sent to either floor 3 or 4 of this building. Both floors 3 and 4 have orthopedically specialized staff. This is where you will spend the rest of your hospital stay until you are discharged to go home. On our postoperative floors, we have all private rooms, and you will not have a roommate. There is a daybed built into the windowsill of every room, so if you have a family member or a friend who wants to rest or sleep on that daybed, they are more than welcome to do so. There's also free Wi-Fi in the building. Go to your settings and you will see Swedish, and it will allow you to log in without a password. After surgery, you are in a new environment and you will be sleepy, and our absolute priority while you are here is to keep you safe. We ask that for your safety, you do not attempt to get out of the bed without the assistance of the nursing or therapy staff. Your room will be equipped with a call light. You will have a remote in your bed, and the most important thing that I want you to remember is the red button in the middle of that remote is your nurse call button. You push it to get the attention of the nurse or nursing assistant to come and assist you with your needs. We are fortunate in our building to have a system that is different than most hospitals. All of our nursing staff are wearing a portable intercom system. You may hear it called Voicera. It is the device you see hanging on the shirt of these 2 staff members. When the nursing staff come onto their shift and they find out which patients they are going to be caring for, your room number gets programmed into their badge for that shift. So when you press the red call button, you are ringing directly to the nursing staff who are taking care of you. In addition to this, throughout the day and night, you will have healthcare providers doing routine check-ins on you and passing important information on about you as shifts change. In your room, you will have a whiteboard on the wall. This is a dry erase board. You can see it easily from your bed or chair, and it has information about you on it that is kept updated. It will have the type of surgery you had, any special precautions that you in particular might need to be following, the names of your nursing staff, and your therapy appointment times. While you are here, you will have scheduled therapy appointments. These are times when someone is going to come into your room and ask you to get out of the bed and move your new joint. It is nice to be able to anticipate when this is going to be happening. If you are on a rapid discharge, you may hear us refer to this as fast forward. The therapist will get you out of bed quickly, usually within about 2 hours of arrival to the room, since patients on that track typically go home within a few hours after surgery. Your diet after surgery will be advanced slowly with the help of your nurse. After anesthesia, we need to make sure that your bowels are awake enough to tolerate food. We put you through a testing process, ice to liquids to food, going slowly to make sure your body can handle this without becoming nauseated or sick. You will notice the nurse may listen to your stomach with a stethoscope. They are listening to hear if your bowels are waking up. Our food system here is called a la carte. I describe this like a room service setup. You are given a menu, and you order what you would like when you would like it. You do this by picking up your bedside phone and dialing 5 5s. The menu is available from 6:30 a.m. to 8:30 p.m. You can order as many times as you would like in that time frame. It will take 30 to 45 minutes to get your food delivered to your room. Noodles and frozen entrees are available if you come back from surgery late and didn't have the opportunity to order food within this window of time. There is a visitor menu if you have someone in the room who wants to order food. It is the same menu that the patient gets with the addition of prices. When you come back from surgery, you will have a couple of lines attached to your body. The IV line, or intravenous line, is the only line placed while you are awake and alert. It is a small plastic catheter placed into one of the veins on your forearm. It is important because it gives us access to your venous system. It is used for hydration and medication purposes. If you need a Foley catheter, this is placed while you are in surgery. This is a small tube placed into the urinary bladder that drains your urine for the first few hours after surgery. If you need a wound drain, this is also placed while you are in surgery. This is a tube tunneled near the incisional area. After surgery, if you look at your bandage on your knee or hip, you will see a tiny tube coming out of the bandage attached to a collection device that is sitting there in the bed with you. This is gently pulling drainage into the collection device instead of letting it stay inside your body. Lastly is a peripheral nerve catheter. This is for the knee patients only, and I will explain this in one moment when I talk about pain management. Our goal for pain management after this surgery is twofold. We want you to be able to rest comfortably and get good, deep, restful healing, but we also want you to be able to tolerate doing some activity. One of the keys to a successful joint replacement surgery is getting the new joint in motion. You will be asked many times to rate your pain on a pain scale. This is our objective way of finding out how you are doing. 0 is no pain. 10 is the worst pain you can imagine having in your lifetime. Since every person tolerates a different level of pain, the nursing staff will ask for your personal tolerable level of pain. This is a goal number that you choose, and we will try to avoid your pain climbing over that number if that is at all possible. I do give an example number to make this more clear. Many patients, when asked this question, choose 4. So if you chose the number 4, our goal for your recovery becomes to attempt to keep you underneath the number 4. That region, 0 to 4, becomes our goal for you. We often have patients ask why we don't aim for a level 0 pain in all of our patients. The reason behind that is the pain medication we give you will sedate you. It is a sedative. So we could aim for 0, but we would risk over-sedation and we would hinder your recovery after your joint replacement. So our goal is to get enough pain medication in you that you can get up and move your new joint and it is tolerable and successful, but not get so much medication in you that we have taken away all of your alertness that it takes to get out of the bed and do that moving around that is so crucial for your recovery. Finally, it is important to remember that the time to take your pain medication and get it into your system is before your pain gets out of control on the pain scale. Studies show that patients that take a small dose of pain medication early on rather than waiting for the pain to get out of control ultimately overall wind up using less pain medication. Our pain regimen after joint replacement is a multimodal approach. This includes a couple of things. The first part of the multimodal regimen is started in the preoperative area. When you are sitting in the pre-op area, getting ready to go to surgery, a nurse is going to give you a cup full of pills. We call this the preoperative cocktail. I will tell you what comes standard in this cup of pills, but if you have an allergy or an aversion to any of these medications, your surgeon would adjust this to make it appropriate and safe for you. In the preoperative cocktail is Tylenol, Neurontin, that is a non-narcotic pain medication, an anti-inflammatory, and sometimes, not always, they'll give you an extended release narcotic, and if they do, it is typically OxyContin. That slowly releases into your system over about 8 to 12 hours. So for sure, you will receive Tylenol, Neurontin, and an anti-inflammatory, and maybe OxyContin. You are given this cup of pills, you take it with a small sip of water, and it starts releasing into your system. The theory behind this is that when you now go into the operating room, we are partially blocking the flooding of the pain response that would have come over your body, since we've already numbed all those different pain receptors ahead of time, that patients now have less pain post-operatively because of that. Next, after surgery, your doctor will have you on a regimen of pills to control your pain. Oftentimes, this includes a routine anti-inflammatory, possibly some Tylenol, and an as-needed short-acting narcotic, and it is typically oxycodone that is used. Ice will be offered to you to treat your pain. This will be a plastic bag filled up with ice. It will be rotated all around your incisional area. The idea behind ice is that it decreases swelling, therefore decreasing pain. You will use ice packs here at the hospital, and you will continue to use them once you are home. Finally, our knee patients receive one more mode of pain relief, and that is a peripheral nerve catheter. You might hear it referred to as a PNC. This is a tiny catheter placed in your thigh by the anesthesiologist while you are still in the recovery room. The catheter is placed at a nerve bundle where a numbing medication, a local anesthetic, is infused. By dripping that numbing medication on the nerve bundle, it makes your knee area numb locally. So we are decreasing your pain by making your knee numb. The very small catheter that is inserted into your thigh is actually not visible in this picture. What you are seeing here is external tubing that is taped down to the thigh area and connected to a ball filled with numbing medication. In this picture, on the left, you will see a full bag of numbing medication, and on the right, you will see an empty bag of numbing medication. The picture at the bottom shows a purse that you are given to carry the ball of numbing medication when you are up and around. The peripheral nerve catheter usually stays in for 1 to 5 days after surgery. The anesthesiologist will instruct you on care of the catheter at home if you leave the hospital with this in place. A major focus with joint replacement surgery is reducing your risk of infection. We have 3 very specific infection prevention tactics that you will need to know. The first is something you will do at home. You will take 2 showers prior to coming in for your surgery, one the evening before your surgery and one the day of, with a specialty soap called chlorhexidine gluconate 4%. This can be purchased at your local pharmacy, and 1 bottle is enough for both of your showers. You will receive your preoperative shower instructions in your patient guide, Prepping for Surgery, that is mailed to you from your surgeon's office. Once you arrive here at the hospital on your day of surgery, you will do the next 2 steps in the preoperative area. One is to swab your nasal passages with an antiseptic, and the second is to use chlorhexidine gluconate saturated wipes to apply to your body before surgery. All of these measures are aimed at decreasing the bacteria on your body and in your nasal passages before you go into surgery. After surgery, you will not be getting fully inflated lungs like you have right now. This is for a number of reasons. You had anesthesia, you are laying in bed more than you normally would be, and when you are laying in bed, your lungs don't fully inflate like when you are up and walking around. And finally, you will be taking narcotics. Narcotics are a sedative and they sedate your body systems, and your lungs are affected by that. What this can lead to is a shallow breathing pattern that you might not even realize, which can leave areas deep down in the pockets of your lungs sitting stagnant. And if the lungs sit stagnant for too long, infection can have the chance to brew. The good news is that you can work to prevent this by doing some focused deep breathing. The focus is on the long, steady, deep breath in. So it is pulling the air into the lungs and reaching all those areas at the bases and popping them back open again. So it will be a long, steady, deep breath in and a regular breath out. If you have any secretions sitting in your lungs, your body will naturally want to cough. So that is a good thing, to cough and mobilize those secretions out of your lungs. Finally, you may get an incentive spirometer. With this device, you'll do exactly what I just explained, but now you get the device to show you that you are doing it correctly. Put your mouth on the white piece, pull your nice long deep breath in. A blue button will go up to a number, but there is not a goal number. Everyone's lung capacity is different. You can make your own goal once you've done it a couple times and see where you can reach. Regardless of whether you have an incentive spirometer or not, as long as you are aware and doing the deep breathing, you will be keeping the lungs healthy. Many of our patients become constipated after surgery. This is due to the use of narcotics. They are very constipating. And we do slow down your mobility. You aren't up and walking around like you normally would be, and as a side effect, that just slows down the bowels. It can take a while to get back to your normal bowel routine. In the hospital, as a proactive measure, all patients are given a medication called Miralax. This is a gentle and safe laxative to take postoperatively. You will want to continue to take this daily at home until you have had a bowel movement. You should stay aware of this issue, as constipation can persist for a while until you are fully off of narcotics and back to your regular mobility. You are welcome to try alternative laxatives, such as Dulcolax tablets, or natural remedies, such as drinking warm prune juice. A good rule of thumb is to never let more than 2 days pass during your recovery without a bowel movement. After any surgery, you are at risk for a blood clot. We have specific measures in place to attempt to prevent this from happening to you. The first is ankle pumping. While you are laying in bed, this is simply pumping the ankles up and down, pointing the toes to the ceiling and then to the wall. Blood clots can occur when blood is not moving. While laying in bed, your calf area is at risk for this. By pumping your ankles, you are flexing the calf muscle and pushing the blood flow back up into circulation. We ask that you pump both legs, not just the surgical leg, at least 10 times every hour while you are awake. Getting out of bed as soon as possible will naturally get your circulation moving. You will come back from the recovery room with sequential compression devices on your legs. These are sleeves wrapped around each lower leg, attached to a cord which is attached to a pump at the end of the bed. Periodically, the pump directs air through the tubes, inflating the sleeves. This is one more thing aimed at getting the circulation going. The final measure aimed at preventing blood clots is a blood thinner medication. All patients who have this surgery are put on one. Your surgeon will assess your individual risk factors and choose a medication that is appropriate for you. Patients are commonly prescribed aspirin or Coumadin. You are typically on this medication for 4 to 6 weeks after surgery. If you get placed on the medication Coumadin, your blood will need to be watched via a blood test once or twice a week for the length of time you take it. This is so that we can make sure the blood is maintaining an appropriate level of thin. Depending on your insurance, this can either be done by home health services or by coming into a clinic. This will be discussed with you while you are here at the hospital, and if home health is covered, our home care coordinator will assist you. If you are placed on aspirin, blood testing is not necessary. In regards to therapy, you will be seen by both a physical therapist and an occupational therapist while you are here. Here are the official definitions of a physical therapist and an occupational therapist. An easier way to think about this is that the physical therapist will focus on your body. They will teach you body positioning, they will teach you exercises, and they will work you out. They are your personal trainer. Occupational therapy will focus on your home. They will ask you questions about your home environment and make sure that you are prepared to return to that home environment and have a safe recovery. Our physical therapists will want you to meet a set of goals before we send you home from the hospital. You'll want to be able to transfer in and out of bed safely, to walk at least 50 feet using either a walker or crutches, that you are able to do any exercises they teach you correctly, that you are able to do stairs and curbs as needed, and that you are discharged home with the appropriate equipment. Occupational therapy also has goals for your discharge, that you'll be able to transfer safely to your home toilet and shower or tub, that you have the right adaptive equipment to keep you safe at home, and overall, to be able to return to your day-to-day life activities. Occupational therapy would like you to think about the safety of your home environment before you come in for surgery. After surgery, common objects become trip hazards. Some examples of this are electrical cords, debris, throw rugs, and pets. Remember to prepare your home and remove trip hazards a few days prior to your surgery date. While you are here, some therapy happens in your hospital room and some in a larger therapy room. This allows the therapist to do any home simulation that they feel necessary, such as techniques for getting in and out of a car or walking stairs. For the hospital stay, pack a small bag with 2 outfits. Make sure you have loose-fitting bottoms or shorts to allow ease in exercising the new joint. Baggy shorts work great. Now we're going to talk about equipment you might be using after surgery. This is the one piece of equipment that is required: a walker or crutches. Your physical therapist will help you decide which assistive device is best for you and will adjust it to fit you. This is some equipment that isn't necessarily required but might be recommended depending on how you are moving after surgery and what you report about your home environment. A raised toilet seat is a thick piece of circular plastic. You would place this on your home toilet, and it decreases the distance that you have to get seated and decreases the distance to stand back up again. The taller of an individual you are, and the lower your toilet seat at home is, the more beneficial this device would be for you. The bedside commode is the same idea. It elevates the seat, but it also gives you armrests. The next device that may be convenient for you is a shower chair. And finally, a reacher. This is a long metal stick with a pincher at the end and a trigger at the top that activates the pincher. Some of your equipment after surgery may not be covered by your insurance. To know for sure, you can call them ahead of time to find out what they will cover. There are 3 ways that you can get your equipment: new, rented, or used. If you would like to get your equipment here at the Swedish Orthopedic Institute, there is a vendor located on the lobby level of this building, but you are welcome to purchase your equipment anywhere you'd like. The vendor will deliver any equipment you need to your hospital room, and you would leave the hospital with that equipment. If you choose to rent, or obtain the equipment used, we do ask that you do that ahead of time, since it takes more time than purchasing it new. A few options for used equipment are Lions clubs, thrift stores, hospices, and churches, which sometimes have medical loaner closets. There are many places out there to find mildly used medical equipment. The only piece of equipment, if you obtain it used, that we will want to see is the walker or crutches. That is because they have a height adjustment, and we will want to make sure that it is adjusted appropriately for you. It is crucial to have a discharge plan in place before you have your surgery. Most patients plan to go directly home or home to a friend or family member's house. It is very helpful to have a room set up for your recovery. A comfortable room with a TV, easy access to the bathroom, and most importantly, a chair with arms at a good height you can sit in. Typically, people utilize a walker or crutches for 1 to 2 weeks post-surgery. It is nice to have help during meal times when you can't carry a plate or a cup to the table. It is also helpful to wear an apron or a shirt with a lot of pockets, so your hands are left free to keep you safely holding onto your walker. If you have stairs at home, you will want to share with the therapist how many stairs so that they can teach you techniques to keep you very stable on those stairs. They will ask that you have a good sturdy railing on at least one side of the stairs and that you have someone with you while you are attempting stairs. You are ready for discharge to home when your therapy goals are met. For some of you on a rapid discharge, sometimes called fast forward, that will be as early as the afternoon or evening of your surgery. For others, it will be the first or second day after surgery. On the day you are going home, you'll need comfortable clothes and shoes that are easy to take on and off. You will want to have a ride arranged for the day you go home. If you stay the night at the hospital, the discharge time is 11 a.m., but this can vary sometimes depending on if you have any therapy appointments to attend before leaving the hospital. If you are going home on the day you had your surgery, the 11 a.m. discharge time does not apply. You are sent home with paper prescriptions for your discharge medications, except for Kaiser patients who receive their discharge medications prior to surgery. Finally, here are some tips to continue a successful recovery at home. Maintain strict hand hygiene, you and everyone who comes into your environment. Continue ankle pumping and deep breathing for about 4 to 6 weeks. The nurse will give you instructions on how to care for your bandage once you are home. A good guideline for activity for the first couple of weeks is to try to be active for about 10 to 15 minutes of every hour during the day. This could be spent doing your therapy exercises or simply walking to the bathroom and back again. Don't be afraid to take long 30 to 45-minute naps in between your periods of activity. A good balance of activity and rest is crucial to your recovery. Leg elevation is important. Your incisional area will swell, particularly for the knee patients. Try to elevate your leg at least 2 to 3 times a day on a few pillows for 20 to 30 minutes to help decrease this swelling. For knee patients, make sure that your knee is elevated above the level of your heart and the leg is as straight as it can be. This will help your body reabsorb the fluid buildup. For hip patients, you are welcome to place a pillow underneath the knee. You are welcomed and encouraged to change positions frequently. Rolling onto your non-surgical side with pillows tucked between the legs is a comfortable position for many patients and is safe. Thank you for watching this seminar. As noted in the beginning, please feel free to contact me or our Joint Program Coordinator, Kim Rains, with any questions you may have, utilizing our contact information that you'll see on the final slide. We hope you found this informative, and we look forward to guiding you through your joint journey.